Olá, olá, colegas. Buenos dias a todas, a todos. Sou Alexandre Lengruber, assessor regional de avaliação de tecnologias e acesso da Organização Pan-Americana da Saúde, secretariado de RedETSA. Vamos a dar um par de minutos para que todos puedan entrar em la sala. Muchas gracias por la participación en más esta edición de los webinarios de RedETSA. Me gustaría agradecer a todo el equipo de organización aquí de nuestro secretariado. No voy a mencionar todos los nombres, mencionar a Marlene Roman. Marlene, muchas gracias por todo el apoyo, toda la organización e vários outros colegas que participam do secretariado, Vânia, Caroline, pero Marlene Roman diretamente ela é responsável por coordenar esse programa e várias outras atividades do secretariado. Assim também toda a nossa equipe de apoio administrativo, Lisete e todos os intérpretes já deixaram nossos agradecimentos. E, obviamente, a todos vocês, membros de RedETSA, que participam sempre ativamente de nossas reuniões. Recordar que temos interpretação simultânea, hoje temos duas apresentações em inglês, assim que aqueles que necessitam de interpretação, por favor, podem fazer uso aqui por el globito aqui de interpretação na parte de abaixo de la pantalla. Ok? Bien, nosotros hoy teníamos entonces, quería dar las bienvenidas a ustedes para más esta edición de número 38 del programa de webinarios RedETSA. El tema de hoy que tenemos es reflexiones sobre el uso de la evidencia del mundo real em evaluações de tecnologias sanitárias. Vamos a escuchar experiências de Inglaterra e de Canadá. Dizer que essa sessão vai ser, já está sendo gravada, assim que se há alguém que não esteja de acordo, por favor, nos avisem, mas esperamos que não. Esperamos que esteja tudo bem. Temos, como mencionei, interpretação em inglês e espanhol, e dizer que este webinário e todos os webinários de RedETSA estão em nossa página de nossa rede e também em nosso canal de Parro em YouTube, ok? Queria agradecer a todos vocês e também a nossos expositores. Hoje temos Stephen Duffield, do National Institute for Health and Care Excellence, NICE, de Inglaterra, e Melissa Caron, do Instituto Nacional de Excelência em Santé e Serviços Sociaux, INES, de Canadá. E também a nosso grupo de trabalho sobre este tema de Real World Evidence de RedETSA. Agradecer a Guadalupe Monteiro, de RedETSA de Argentina, Sebastián García Martí, de IEX de Argentina, e a Graciela Fernandes, do Fundo Nacional de Recursos de Uruguai. Como vocês sabem, a evidência do mundo real tem um papel cada vez maior no contexto da avaliação de tecnologia sanitária e a toma de decisões em saúde. Sabemos que às vezes é necessário tomar decisões de cobertura e a realização dos ensaios clínicos não é possível. Em algumas dessas ocasiões, você pode recorrer a estudos com chamados dados da vida real. É muito importante ter em conta como se generam esses dados, que tipo de desenhos e base de dados realizar, como analisar esses dados para poder ter informação de boa qualidade. Os possíveis usos da evidência em mundo real podem se desenvolver registro de enfermidades, obter dados complementares em ensaios clínicos, estimar carga de enfermidade, monitorear o desempenho de uma tecnologia ou realizar acordo de risco compartido, entre outros. A evidência em mundo real proporciona dados de efetividade a grande escala que melhoram nosso conhecimento sobre as estratégias terapêuticas e, portanto, sua utilidade e alcance são cada vez maiores. Sabemos de grande interesse que há deste tema em nossa rede e, por isso, já hemos discutido esse tema em outras ocasiões, mas nos pareceu importante regressar a este tema e organizar esse webinário, escutando, primeiramente, a duas experiências de fora de já ia mencionar fora da região, perdão, pero uma experiência de la região e outra experiência de fora da região, ou seja, uma de Canadá e outra de Inglaterra, uma de membro de RedETSA, Inês, e outra, Nice, de fora de RedETSA, e depois temos nossos 3 participantes de RedETSA, de grupo de trabalho. A maneira como organizamos essa sessão, eu vou moderar a primeira parte, eu vou apresentar os ponentes, e depois vamos ter as 2 primeiras apresentações, depois Marlene vai assumir a moderação da segunda parte com nosso grupo de trabalho e as perguntas, e eu regressarei então ao final para nossa série, ok? Então, passamos a nossa primeira apresentação, vamos escutar o Dr. Stephen Duffield, que é médico, diretor associado em métodos de Real-World Evidence em NICE, onde trabalha desde 2019. O papel de Stephen implica o desenvolvimento do marco de evidência de mundo real, de NICE, a colaboração em projetos de demonstração de Real-World Evidence e ajudar a transformar o uso de dados do mundo real por parte de NICE em todos os produtos de orientação. Stephen também participa na melhora das habilidades de pessoas dentro e fora da organização, contribuindo a talleres de capacitação e fóruns técnicos. Stephen tem uma licenciatura em medicina e um doutorado em saúde pública. Anteriormente, trabalhou como médico clínico e desarrollador de guias em centro de guias de NICE. Stephen, thank you so much for being with us. We are really glad that you accept this invitation to share the experience from NICE. As you know, NICE is an institution very well respected, well recognized internationally, but also, of course, in our region. So we are really glad to accept this invitation. The floor is yours.
Thank you very much, Alexandre. Let me just get set up so that you can all see everything you need to see. Okay, and let me share my slides. So what you should be seeing now is the title slides, and someone can tell me if they're not seeing those.
Perfect.
Cool, sounds great. Okay, so firstly, good morning. Thank you very much for the introduction, Alexandre, for the invitation to come and speak on this topic. Obviously, we've been doing a lot of thinking about this within NICE. So I'm Steve Duffield, Associate Director for Real Evidence Methods, and I work on the team, which is the team that helped to produce NICE's Real Evidence Framework, which some of you may be familiar with. So today I'm going to cover a bit about real-world data and our data infrastructure within the UK, the contents of the framework, and how real-world evidence is currently being employed within NICE. Cool. So what is real-world data? So this is just to say that the definition of real-world data and real-world evidence that we use in NICE is slightly different to that of some other organizations. So we define real-world data as data which is collected outside of the highly controlled clinical trial environment. So this includes evidence that is generated from audits, service evaluations, and devices such as wearable devices. Then there's a more kind of classic real-world evidence, so the routinely collected data, for example, from administrative records or electronic health records, or then primary data which is collected through registries and observational studies or surveys. So we like this definition as it helps to recognize that many elements of data suitability and robust methods are common across these sources of data. It also helps to avoid issues of definition. So for example, is a registry a research study? Is it primary data collection, or is it routinely collected data? So anyway, that's how we define real-world data, and real-world evidence then is evidence which is produced using real-world data. So what does the data landscape look like in the UK? Let's start low resolution. So we have our national registries. So these often provide really good representative data, perhaps even covering 100% of patients treated in the NHS. That's the English healthcare system. And this can give us that really good representative data. However, these tend to be lacking for the data elements that we require for certain specific research questions. So particularly around things like comparative treatment effects questions, which typically need really rich, robust data on things like covariates and outcomes over follow-up. On the other end of the scale, we have clinical research data sets. So these may have really rich information of the kind that we need to address our research problems. However, they're often quite poor patient coverage, which may lead to something of an external validity problem. Finally, there's where most of the data is, which is in routinely collected data. Here we have really good coverage of patients, and if we were able to get at it, probably all of the features that we need. However, there's huge amounts of missingness across patients. So this leaves some tantalizing possibilities regarding reducing that missingness, which could potentially be unlocked through the use of newer AI methods, which can make use of unstructured data, which is stored away in clinical notes. Going higher resolution, the reality is a bit more complicated than that. We have a complex web of data sources, data extractors, and data consumers. So how do we find what we need? One of the ways we can improve data discoverability is through searchable registries of data sources. So in the UK, we have something called the HTA UK Innovation Gateway. This is a searchable registry of data sources, and it's currently helping us to be able to identify the data that we need at the point at which we need it through services like this one. Besides data discoverability, one of the other barriers to the use of real-world data in the UK has been trust. When the UK government initially set out to make use of its national primary data care resources, it was hit by large opt-out rates. The general public did not trust that its data would be used appropriately. So the national UK strategy around healthcare data is now to address the issue of trustworthiness head-on. The key solutions here is for this data to be accessed and analyzed in secure data environments, or SDEs. So what this means is that the data is accessed securely via a portal. Users of the data can access and analyze data without that data ever having to leave its environment. So hopefully gone will be the days where large files of patient data are carried around on memory sticks. Additional developments in this area mean that analysts can run their analytical code on synthetic data before it is applied to real patient data. This means that the analyst will never be able to review raw individual patient data, which could add an extra layer of privacy and security. There's also an element of an audit trail. So every analysis performed within the SDE is logged and we know who performed it, and this can be tracked for transparency. So we'll have the national SDE, which provides access to national NHS data and social care data. And we'll have access to more regional data collections. These are called subnational SDEs. This will allow NICE to benefit from national data which has good coverage, but may not have all of the data items that we need. And then regional data collections, which are potentially richer and more flexible, helping us to answer all the questions that we need to answer. So enough about data in England. How do we actually use it in HTA? So data is the building blocks which we use to create real-world evidence. However, in reality, its quality can be extremely variable, and the robustness of study designs can be equally difficult to determine. And this was the reason for the development of NICE's real-world evidence framework. NICE made clear as part of its transformation plan its ambition to make greater and better use of real-world evidence to fill evidence gaps and speed up patient access to innovative treatments. The key focus areas here were to improve access to high-quality real-world data, to make sure that it's timely at the point of decision-making, to increase the routine use of high-quality real-world evidence across our guidance products, to build capability, not just improving our analytical capabilities to use this data, but also the capabilities of our decision-making committees to be able to draw conclusions from this evidence. Signposting technology developers on their evidence development plans at the right stage of their evidence generation journeys is also important to reduce research waste and make sure that the evidence that arrives at NICE is the kind that we can use. And then we also are interested in attracting high-impact collaborations with other national and international leaders in real-world evidence and health and care. We can't do this alone. It's an extremely complicated and fast-developing area of research, and so we need to share our learning internationally. Playing a significant role in NICE's transformation journey has been the publication of NICE's real-world evidence framework, published in June of last year. It's a document available online, which firstly describes where and how real-world evidence can be used to improve recommendations. And then the second half is all about best practice principles for planning, conducting, and reporting of this kind of evidence. The framework was supported and informed by literature reviews and existing best practice guidance for the use of real-world data. It also underwent several rounds of consultation. There was internal consultation, a series of external multi-stakeholder workshops, and we made sure that this also included perspectives from outside of the traditional drugs type industry, but also medtech industry and life sciences. And then there was an open consultation, which happened in April of 2022. The framework starts by outlining what real-world evidence is and how real-world evidence can be used to improve recommendations across NICE. We also show that there is a multitude of uses for real-world evidence in guideline development, many of which are already common across NICE. So, for example, real-world data can be used to provide patient and user experiences through surveys or focus groups, for example. It can help describe and characterize the disease population, care pathway, or outcomes of interest. It can look at the impact of technologies on the delivery of care itself, for example, new diagnostic or predictive tests or operational systems. It can assess the generalizability of existing trials to the UK context, or it can look at the impact of new technologies on the patients themselves or resources. So that would be your comparative effects type questions. And all this information and more can be used to help populate and validate economic models on which cost-effectiveness judgments are made. So in actuality, NICE already uses real-world evidence quite a bit. And the use of real-world evidence to support guidance has been increasing over the past decade, with around 80% now of new single technology appraisals being supported by real-world evidence. You can see key points in NICE's real-world evidence journey have been the establishment of the Cancer Drugs Fund and our Managed Access Program, which allows early access to treatment while uncertainties are resolved, in part using real-world evidence to do that. However, we recognize there's still tons of untapped potential, both in terms of the range of uses and potential influence of these kinds of evidence. So other than describing where real-world evidence can be used, the framework also defines best practice principles for developing real-world evidence. At the very highest level, the principles include transparency, that evidence is generated in a transparent way with integrity from study planning through to study conduct and reporting. Data suitability, that the used data is trustworthy, relevant, and of sufficient quality to answer the research question. And finally, that analytical methods are used that minimize the risk of bias and characterize uncertainty. The framework does not provide minimum standards, as different use cases for real-world evidence may have different level of scrutiny based on their influence on recommendations, among other factors. The framework primarily, therefore, aims to encourage best practice and to show what good looks like. The framework also includes reference to several available tools. These can help developers in producing higher quality evidence at different stages of the development process. So it was very important to us not to just produce a guidance document, but that this document should be highly implementable. And so we wanted to provide tools and resources to ensure that people developing the evidence were able to do that to the standard that NICE requires. So let's talk a bit more about transparent reporting. Transparency is vital, particularly for real-world evidence studies, which can be complex and hard to understand, because it enables reviewers. It enables reviewers to understand what was done, but also builds confidence in the results. And ideally, it should be sufficient to allow reproducibility of the results. Evidence developers can also consider transparency as a key tool to ensure that their high-quality work gets recognized as such. The framework recommends data and methods should be well described, including demonstration of the provenance of the data source and fitness for purpose. So we'll talk about that a bit more in a moment. Also, a description of all methods from data curation to study design to analysis is needed. And then reporting of results should include information about patient flow from the data source to participation rates in the study, to loss to follow-up, and reasons for any exclusions at each stage, with presentation of patient characteristics by intervention or subgroup. Obviously, it's important also to have the results of both planned and any unplanned analyses. So as I mentioned, the framework links to several tools in this area to make the guidance as implementable as possible. So they include protocol, study design, and results reporting tools like Start Real World Evidence, or the more recently published Harper tool, data source reporting tools such as NICE's developed DataSat tool, and then study registries to show that your work has been pre-specified, and reporting checklists such as SPROVE and RECORD-PE. So just a bit more on how NICE defines data suitability, and I'm reminded of one of the appraisals that occurred just prior to the publication of the framework. So this was pralsetinib for RET fusion-positive non-small cell lung cancer. This evidence submission included an indirect treatment comparison between a trial arm and a real-world data source. And this was rejected by the committee for a number of reasons. But one of the key ones was that the decision-making committee simply did not know how to assess the quality of the data sources which were used. So I'm happy to report this is not the case now, and through the framework, NICE has made a really clear statement about what it means when it talks about data suitability. So data suitability consists of two main aspects: data provenance and fitness for purpose. Data provenance relates to features of the data which are separate from the research question of interest. So we want to know about the general trustworthiness of the data source, and developers can provide that by telling us about the original purpose of data collection, what data was collected where, how, by who, any data documentation, so data dictionaries, quality management processes, or data governance arrangements. And then fitness for purpose relates to the quality of the data with regard to the specific research question being answered. And this consists of both quality and relevance. So data quality, we want to know about completeness of the data for key study variables and reasons why data may be missing, the accuracy of the data and how this accuracy was assessed, for example, any available validation studies. With regard to data relevance, we want to know whether all relevant study variables are included, if the population in the data source is similar to the target population for the intervention, if the care settings are relevant to the NHS context, and if sample size and observational period are sufficient to be useful. In order to support the transparent reporting of all of these aspects, the real-world evidence framework includes this DataSat tool, which is essentially kind of reporting form that developers can fill out to make sure they've reported all important aspects of their data to support consistent and structured reporting. And ultimately, to help committees, such as decision-making committees you may have in your own countries, to be able to make a thorough assessment of the suitability of the real-world data sources used. So how is real-world evidence impacting guidance since the publication of the framework? I wanted to start by looking at descriptive uses of real-world evidence. When talking about real-world evidence, we tend to focus on comparative treatment effects, but in appraisals and particularly cost-effectiveness models, the need for high-quality descriptive data can be just as important and influential. The real-world evidence framework states that for most applications outside of comparative effects estimation, real-world evidence that represents the population of interest, that's the UK population for us, this tends to be the preferred source of evidence. So apologies in advance for the small writing on the slide. So this is from a recent publication where I put together some influential uses for real-world evidence since the publication of the framework. By no means exhaustive, but reflect examples of uses which were prominent in discussions by committee members. So I include it here as I wanted to make the point that in most cases where we use real-world evidence, it is to answer these descriptive questions rather than relative treatment effects. Although even descriptive data can be supportive of relative treatment effects. So for example, you can see on the first line that real-world evidence was used to demonstrate that the baseline characteristics of patients in the presented randomized controlled trials were similar and generalizable to the UK population. Similarly, real-world evidence has been used to demonstrate that the outcomes being observed in key trial data are being reflected in routine practice, such as treatments which are receiving early access through our Cancer Drugs Fund. And this kind of contextualizing information can be also useful to address any concerns about the external validity of trial data. Then we have important uses of real-world evidence to support health economic modeling. Again, this is mostly descriptive and includes uses such as to estimate cost per diagnostic test of a diagnostic technology, to define baseline event rates, to estimate the dose of treatment given in clinical practice, which can be important to estimate its cost, to estimate the rates of complications of treatments, types of subsequent therapies, or rates of moving from one health state into another after the available trial data has come to an end. Again, all of these factors can be important drivers of cost-effectiveness analysis in economic modeling, and therefore they require rich descriptive real-world data. So I just want to show you the Pathways pilot project at NICE. So this is one exciting change which is happening at NICE. Perhaps it is not receiving as much attention as it should, but essentially what would normally happen at NICE in an appraisal is that a company would bring their own economic model, which would focus on one specific indication within the whole disease pathway. And this can be problematic as different companies might define their population, their comparative treatments, or other parameters in the economic model slightly differently across different appraisals, even for the same treatment indication. So what this pilot is doing is seeing whether we can define a common whole disease pathway up front using the best quality real-world data available, then a company will, say, come along with relative effects from a new trial, and this can be entered as new information into an existing pathways model. So we're testing out this approach across topics such as renal cell carcinoma, and what this should allow us to do is to both speed up appraisals, as many of the assumptions will have been agreed up front when the model was first developed, and then also to encourage a consistency across appraisals so that treatments can be compared on a level playing field. The overarching point is that the importance of and demand for good quality descriptive information from real data is likely to become more important as we move to developing these kinds of economic models. So what about real-world evidence of comparative treatment effects? This remains perhaps the more contentious use of real-world evidence. The framework is clear that randomized trials remain the preferred standard of evidence here, although real-world evidence can be used to answer these questions in the absence of trials or to answer different but related questions about treatment effectiveness. So this is a simple slide really just to show that the use of real-world evidence to support comparative treatment effect estimation, it varies depending on the availability of real data for that intervention. So for example, when it's a new intervention, there may not be a lot of routinely collected data and its potential uses may be limited. But once in routine use, the potential use cases increase with the availability of data. There are some contextual changes which are bringing these kinds of real-world evidence to the fore. So firstly, it's worth pointing out that we have some good problems, as the developments in health technologies are enabling a flood of innovative new treatments to the market, including genetic immunotherapies, targeted drug therapies in cancer, genetics, and inflammatory disorders. And the general trend of these treatments is towards increasing personalization and subsetting in the treatment of diseases, including targeting ever rarer disease populations. More treatment options on the market means more complex treatment pathways and greater possible variation in standard of care across country contexts. This is particularly an issue in medtech, where there's often an unclear standard of care. There's also more movement away from static treatments, with focus increasingly on sequences of treatments. And of course, in medtech, the actual intervention itself may be constantly evolving. Finally, there's the simple fact that we are now increasingly collecting real-world data routinely. So is it ethical, you could argue, not to make use of this data where possible to improve our decision-making? Finally, patients in orphan disease areas or other areas with high burden are increasingly unwilling to be randomized to non-treatment groups. So what does all this mean? Well, in the evidence landscape, randomized controlled trials are becoming increasingly insufficient or infeasible by themselves for the comparative effects use case, which tends to be the more influential use case for real-world evidence. So this means to some extent, we're going to have to learn to live with real-world evidence and indeed benefit from the advantages that it offers to complement randomized controlled trial evidence. So as we know, real-world evidence is often not perfect, and common methodological pitfalls may lead to biased estimates. In addition, estimates of comparative effect are often influential in committee decision-making, which is why we tend to have more stringent standards for these kinds of studies. So the real-world evidence framework provides advice around how to robustly form these kinds of studies, particularly focusing on cohort studies, single-arm trials with real external controls. These tend to be the more common kinds of study designs seen at NICE. So I won't dwell on this because I realize we're running over time, but we focus our recommendations around robust study design using the target trial approach, and then analytical methods would form the next ring out, which would be all about addressing confounding and information bias. And then no matter how strong your real-world evidence design is, there will always be areas of remaining uncertainty, which is where we recommend robust sensitivity analysis. The framework provides a table of potential sensitivity analyses that developers may want to attempt. And then we also recommend quantitative bias analysis, which is a way in which you can actually attempt to quantify the level of bias in your study and assess whether that's likely to change the impact or to impact the results that you found. So again, I'm going to have to skim over this slide a little bit, but this was a really strong example, I think, of the use of the real-world evidence framework within a NICE appraisal. Essentially, this is an example of a single-arm trial with a real-world external control. And the committee, they had concerns about this, how the company had gone about it, and they recommended that the company go away, check out the real-world evidence framework, and try and apply the methods within the framework. And the company did respond and made some changes. However, their submission could have been strengthened if they'd followed some additional guidance which was laid out in the framework. So do go and check out this. The discussion is available online. So just to say, these are the areas in which the real-world evidence framework is currently being cited a lot within NICE. So you'll notice that most of these are actually in the comparative effects use cases. But this table shows two things, I think. It shows that, firstly, the framework's being cited in the more complex use cases, which would be around comparative treatment effects, but also that real-world evidence is currently being accepted, and even for the comparative treatment effects question. And you can see that most of these appraisals received a positive recommendation. So I'm just going to leave it there, and thank you very much for your attention.
Thank you very much, Stephen. Very, very clear presentation, and I think it will be lots of interesting questions. So just to remind everyone that we are going to keep our questions to the end. So then we can have all the panelists together after after two presentations, and then we have our colleagues from the RedETSA working group, and with their comments, and then in the end we have the round of questions. As I explained, I will introduce our next speaker, and then after that, Marlene Holman will be taking the role as the moderator for the next part of the webinar, and then also for the round of Q&A, questions and answers. Okay, so I will switch to Spanish again. Voy entonces a presentar nuestra próxima ponente, Melissa Caron. Melissa, I hope I'm not mispronouncing your name. I'm sorry for that. I should have asked you first if it's Caron or Caron. Karen's right?
Oh, you can say Caron. It's whichever is fine.
Oh, so it's French. It's French. Okay,
it's French. Yeah.
French. Oh, okay, Caron. Okay, so thank you. Sorry for that. Melissa Caron trabaja como asesora científica y analista en el INES en la provincia canadiense de Quebec desde 2022. Melissa obtuvo su doctorado en epidemiología en 2020 en la Universidad McGill de Montreal, Quebec. Hoy presentará las oportunidades y desafíos que encuentra utilizar datos del mundo real en sus tareas diarias en el INES. Más específicamente, su charla se centrará en un proyecto reciente para ilustrar las fortalezas y limitaciones del uso de evidencia del mundo real en la evaluación de tecnologías sanitarias. Entonces, queríamos dar también las bienvenidas a la doctora, Dr. Melissa Caron. Melissa, thank you very much for accepting our invitation. Ines is a member of RedETSA that we really lots of interest from other members in the experience of Ines, of course, for several reasons. So we're really glad that Ines joined a few years ago, for a long time now already, since my very good friend Alicia Framarin, who is now retired a few years ago. So thank you so much, Melissa. I think it's the first participation in our meetings, RedETSA meetings. So really glad that you could join us. So Melissa, the floor is yours. Thank you.
Thank you for the introduction, and thank you for having us as well. I'll share my screen. So how does this look? Is it in the presentation mode okay?
Perfect.
Excellent. So again, thank you so much for the introduction and for having me on behalf of INES here today. So I am a scientific advisor and analyst at INES, and what I want to share today is really just our experience using health administrative data at INES, how we use it, under what circumstances, and also the challenges that we encounter when we use it. And I'll be using an example of a recent project we worked on to illustrate some of this. So just to describe a bit who we are, so we fall so we're in the Canadian province of Quebec, and we fall under the Ministry of Health and Social Services. And we're guided by our mission to promote clinical excellence and to optimize the use of health and resources in the health and social services sector. And so our mandates are to assess the clinical benefits and costs of technologies, medications, and health and social service interventions, to produce recommendations and clinical practice guidelines aimed at the optimal use of these technologies, medications, and interventions, to establish criteria to assess their performance and the procedures for implementing and monitoring them, and to promote and support the development of scientific assessment of health technologies, medications, and interventions. So I work for the Bureau des Données Clinico-Administratives, which is our administrative health data unit. And generally speaking, our responsibilities are to acquire administrative data, to evaluate the validity of the data, to, of course, do some data analysis, and to develop novel quantitative methods that can be used on this type of data. So what we have access to as far as health administrative data is a lot of billing data. So we have billing from physicians whenever they provide a service to a patient. They bill to the provincial government in order to get paid. So we have access to the billing of the medical doctors. We have access to prescription refunds. So a certain segment of our population is eligible under the Quebec prescription insurance plan to be reimbursed for certain prescriptions. So we have access to this information. We have data on all of the hospitalizations that have occurred in the province, on emergency room department visits. We also have registries, so vital statistics, the births and deaths that have been reported in the province, a cancer registry, a trauma registry, and with these databases, we've been able to build some cohorts, so notably for diabetes, COPD, and COVID-19. So the data encompasses the entire population of Quebec. We're about 8.3 million people, and the databases are paired using a unique ID, so we can follow the health and care trajectory of Quebecers over time. Some databases have over 30 years of longitudinal data, and the data volume is considerable. So we have about 1.7 million deaths recorded, 80 million lines per year of physician billing, 200 million lines per year of prescription billing, and overall this amounts to nearly 1,500 variables across all databases. So this is an incredible wealth of information that's available, and it can complement data that we see in the literature that's more clinical data for clinical research. And it doesn't come with the caveat of having external validity problems, since we don't really have selection bias, given that we cover the whole provincial population. And you know, as a very eager student coming out of my academic career and starting my career at INES, it's so easy to want to jump into this and just get straight into analyzing it and being very excited because there's so much at our disposal and so much that you can do with it. But I learned very quickly that caution must be exerted when data collected for administrative purposes is used in the context of answering a clinical research question. So this brings us to wonder, you know, which questions can administrative health data be used to answer, and rarely is it suitable to answer a clinical research question. I think there are a lot of expectations given the wealth of the data, but without patient medical records, without this clinical data, it becomes very difficult to answer a specific clinical question. So a lot of thought has to go into how we use this data and to what end. And we often need to rework a clinical question into something that our data can answer. And this isn't always obvious. And, we don't want to disappoint our clients who may have, they have certain objectives they'd like to attain. But often what we can do is answer a component of a question. Sometimes our results bring up more answers than questions. More questions than answers. But generally, what we can do is provide complementary information to help better understand a question and perhaps to help make a decision in the assessment of health technology. So if I dive into the example of the project we had this past year, so we were looking at medical imaging for lower back pain. And the original aim was to quantify the extent of low-value diagnostic imaging for lower back pain in the province. And so low-value diagnostic imaging was defined as imaging that was performed in the absence of persistent pain or worrying signs and symptoms in people who had lower back pain. And so in order to answer this specific question, there are three elements that we would need. We would need to have all the diagnostic imaging tests performed on the spine in the province. We would need all the medical consultations that occurred for lower back pain. And among those patients, we would need to know which patients had persistent pain or worrying signs and symptoms. So right off the bat, the middle rectangle and the one on the right for the consultations for lower back pain and the worrying signs and symptoms and persistent pain, we have major quality issues associated with this type of data in our databases. So diagnostic data like that type of data is all dependent on the physician billing. And when a physician bills for a visit for when they've seen a patient, they're not obliged to input a diagnosis. They're really just, billing for a visit for a service in order to be paid. And so in about 40% of these visits, the diagnosis is missing. So this is not really reliable data that we have in our data sets. We found that for more acute diagnoses like cancer, the data can be more complete and more reliable. And for things like diabetes and COPD, we can, look at the history of the patient's use of the healthcare system, and we can get an idea that they may have diabetes or COPD. But for something as general as lower back pain, it's incredibly challenging to know that we've captured absolutely everything. As far as for diagnostic imaging tests performed, that is more reliable in the databases that we have, since radiologists will bill for an imaging test that was performed. But nevertheless, we need to ask ourselves, is this data valid? Are the codes complete? How are they used from one establishment or from one region to another? And these are the types of questions that we need to evaluate with every project of ours. So our original aim was to quantify low-value diagnostic imaging for lower back pain, but amid some reflections, negotiations, and rethinking of the clinical question, we turned it into something that was a little more operational given the quality of the data that we have. And we chose to describe diagnostic imaging of the spine and hope that this could provide some form of proxy a bit to low-value diagnostic imaging. So we looked at things like rates of use of diagnostic imaging of the spine, evolution over time, whether these imaging tests were repeated. And I'll emphasize here regional differences because this comparison in particular of regions or of similar establishments can be very informative. It's what can allow for further reflections. What practices give way to these regional differences? Does that include, low-value diagnostic imaging? And it allows for reflections in the field too. So a region or an establishment may use this information to further reflect on their practice, and it may also bring up some red flags that they didn't realize were there. So contextualizing the use of these exams or this imaging can generate some thought-provoking conversations on low-value diagnostic imaging and some further reflections on the topic. So if we look at the types of diagnostic imaging of the spine that we had in our databases, so these are the different codes that are billed for MRIs, CTs, and X-rays. And right off the bat, we see that the level of detail and precision varies between the different types of imaging. And something that's incredibly important for us to do at the beginning of every single project is to validate these codes with experts in the field. So in this case, with radiologists who bill for these types of codes. And we found out by speaking with these experts that some codes aren't necessary for our project or aren't relevant to our project. So for example, the two in red here, 8057 and 8053, those are more related to osteoporosis and scoliosis. And, without speaking with experts, we never really would have known that they were used under those circumstances. So every time we use our administrative data, we always validate what we're doing with experts in the field to ensure that we're really answering the question that's at hand. And something to keep in mind here as well is that these are not standard codes like ICD-10 codes. So they're associated, they're used for billing, they're associated with a price, they change over time, they disappear. So it's incredibly important to understand their history and how they've been used. So these are some of the first types of results that we'll produce for a research question like this. So this is just the age standardized rates per 1,000 people from 2010 to 2019 for the 3 different types of medical imaging. We see that some have increased more over time than others. And the first thing we'll ask ourselves are these values plausible? And again, we always go back to the experts in the field and let them weigh in. And they tell us if this resembles what they're seeing in their daily practice. And they can start giving us explanations for why MRIs have increased so much in the last 10 years. So this is a form of validating our data at the beginning of a project. It starts to get a little more interesting here when we compare regions. So again, we have age standardized rates of MRI use on the left-hand side and CT use on the right-hand side per 1,000 people by region in Quebec. And we find that in the absence of clinical data, by doing something like this, we can still emphasize differences and highlight variations in practices. And there are, of course, different factors that can explain these differences. It can be due to differences in access to the technology, but of course, some maybe unexplained differences could also be due to it could be an indirect measure of low value care. So these again are the age standardized rates per 1,000 people by region, but in this case for X-rays. And what I want to point out here is as a hiccup that we noticed as we were doing our data analysis. So we expect to see a lot of variability between regions, but in this case, we noticed 5 regions that had particularly low rates of X-ray use, and it didn't seem quite right. And we didn't really know what to make of this, and neither did the experts we were speaking to at the beginning. And again, continuing with X-rays, when we looked at the setting under which they were done, so in blue here we have X-rays or imagings that were done electively, so as an outpatient. In green, it was during a hospital stay, and in gray would be during an emergency room visit. Essentially, all of the X-rays were done electively in our data, and we knew this wasn't right, and it didn't correspond to what's actually happening. And so we didn't understand why we were getting these strange results with X-rays, but yet this is what our data is telling us. So when we really started to break things down, we looked at the X-rays that were being performed in a hospital setting versus those being performed in, an outside radiology clinic. And essentially, up until the year 2021, we had virtually no X-rays being documented in hospitals, even though this isn't the case at all. X-rays are done in hospitals all the time in Quebec. And to better understand, what was going on with our health administrative data here, we had to scour the internet, speak with experts, read newsletters. And it was a colleague of mine who happened to come across this newsletter that explained that as of December 1st, 2021, radiologists could not just send their billings in batches, which is what they used to do. They used to send X-ray billings in batches by saying, in the last month, I performed X amount of this test. As of December 1st, 2021, they had to bill per X-ray. And so we finally had the associated X-ray with the patient ID, and it started appearing and populating our database. And the reason why we had those 5 regions with such low rates of X-ray use is because those regions don't have many radiology clinics. So all of the X-rays being performed in hospitals over there were just not available in our database prior to December 1st, 2021. So all of this just to point out that billing codes are rarely perfect. And, in this case, we had to look at things longitudinally to kind of understand what changed over time and what happened to them. And it's, we can't just take this data at face value right off the bat. So here we looked at the percentage of the imaging tests of the spine that were performed on patients who had the same type of imaging done in the previous 365 days. So we thought that, the idea of repeating an imaging test could be a form of a proxy for low-value diagnostic imaging. But again, repeat imaging can constitute regular follow-ups for a specific clinical indication that may be totally warranted, or they may represent low-value diagnostic imaging. So on their own, it's unclear what these percentages represent, and it's hard to tease out whether it's warranted or not. So we always try to add a bit more information or context if we want a proxy for low-value diagnostic imaging. So that's what we did here. We looked at repeat CT imaging, but by hospital here. So we chose comparable hospitals with comparable clienteles and access to services. And so in blue, we have the percentage of CTs that were repeated from a previous CT that was done in the same hospital. And in gray, it would be repetitions of a CT done in another hospital. And, again, just to highlight that in the absence of clinical data, we can show variations in practices between establishments. And so with our data, we feel like we can give tools to these establishments to reflect on their practices. For hospitals 11 and 12 in particular, they have higher rates of repeat imaging, and this repeat imaging may be necessary, but these results can certainly bring them to evaluate their practices. And this in general is very appreciated by the hospitals, even if it doesn't provide a clear answer as to whether the imagings are of low value or not. And finally, another example of a little hiccup we found along the way. We were looking here at percentage of imaging tests of the spine that were performed on the same patient on the same day and by the same doctor. So we're looking at duplicates here. And we found an incredibly high number of duplicates for X-rays. And again, by speaking with radiologists in the field, we found that X-rays performed in radiology clinics, which is essentially all of the X-rays that we have prior to 2021, they are associated with 2 billing codes. So a doctor will bill for a consultation fee and a laboratory fee. And in other words, those X-rays appear twice in our billing database. So midway through our project, we had to look through everything again and remove the duplicates for these particular billing codes. So just to wrap up with the limits of administrative health data, it's not always possible to answer certain clinical questions, especially in the absence of patients' clinical characteristics and medical files. It can be challenging to analyze health problems that are not well documented in the databases. So for example, lower back pain. And our analyses have to be thought through, and we often try to think of them in a more generalized manner using proxies to answer a clinical question. So for instance, comparing rates across regions or across establishments. Billing codes and practices change over time, as we saw with the X-rays. And simply because a variable exists does not mean that this variable is valid and ready to be used. So for all of our projects, we need to identify and use the appropriate billing codes, but when it comes to identifying and interpreting these codes, Google's not our friend, neither is the provincial manual on physician billing. We absolutely and always discuss and validate with experts in the field to understand what's going on. These codes are very complex. Physicians can use them in different ways. They can use the wrong one. They can put in a wrong diagnostic code or put in no diagnostic code whatsoever. However, I do want to end on a positive note, and there is an absolute, despite these limitations, there's an absolute wealth of information in these interconnected databases. To make a study of this grandeur would be incredibly costly. It would be incredibly lengthy, and so it's a privilege to have this amount of data. I just want to end by thanking all of you for your attention, and also for thanking my colleagues on this particular project. Thank you.
Thank you very much, Melissa, for your presentation. It's very interesting to learn more about Ines' work on this topic. Sorry. Excellent example on back pain to see how proper reporting of data is so important for subsequent analysis. Antes de presentar a los próximos expositores, queremos recordarles que pueden realizar sus preguntas en la caja correspondiente debajo de la pantalla del Zoom en Q&A. Ahora voy a darle la palabra al grupo de trabajo de RedETSA sobre Real World Evidence. Van a realizar algunos comentarios sobre estas excelentes presentaciones que hemos podido escuchar. También van a conversar sobre el desarrollo y el uso de la Real World Evidence en Latinoamérica, y van a comentar un poco sobre el trabajo actual que está teniendo este grupo de RedETSA. Ellos son, como anteriormente comentó Alexandre, Sebastián García Martí, del Instituto de Efectividad Clínica y Sanitaria IEX de Argentina, Graciela Fernández, del Fondo Nacional de Recursos de Uruguay, y Guadalupe Montero, de la Red Argentina Pública de Evaluaciones de Tecnologías Sanitarias, RedETSA de Argentina. Gracias.
¿Qué tal? ¿Cómo se encuentran? No sé si podemos prender nuestras cámaras. ¿Qué tal? ¿Cómo están? ¿Cómo se encuentran? Yo soy Sebastián García Martí, soy el coordinador del Grupo de Evaluación de Tecnologías Sanitarias y Evaluaciones Económicas en el IEX. Y junto con Guadalupe Montero y Graciela Fernández formamos parte del grupo de Real World Evidence de RedETSA. Em, yo básicamente tengo una pregunta para Stephen, y es que pensando en la utilización de Real World Evidence en la región, si ustedes en el NICE tienen algunas condiciones específicas o algunas enfermedades particulares en las cuales consideren la utilización de Real World Evidence más útil, o si se vean más tentados a utilizar Real World Evidence en algunas condiciones o intervenciones específicas.
¿Quieren que dejemos para la última parte las preguntas? O Stephen, si quieres contestar ahora, no hay problema también.
Ah, perdón, Malen, yo pensé como que ahora conversábamos entre todos.
Si quieren, conversemos primero sobre el grupo de trabajo de Real World Evidence y después ya avanzamos con todas las preguntas, así no...
Perfecto, perfecto.
Vale, gracias.
Bien, volviendo a las actividades del grupo en la región, en los últimos años hubo una utilización creciente de Real World Evidence, aunque en mi opinión no es fácil el acceso a bases de datos, ¿no? Recién cuando mirábamos las presentaciones y la cantidad de datos que mencionaba Melissa en Canadá, realmente lo primero que me generó fue envidia. La sensación de tener tantos datos para poder evaluar tantas cosas es algo que en la región es mucho más complejo y el acceso a datos no es tan fácil, ¿no? Si yo tuviera como que dividir las potenciales utilidades de Real World Evidence en la región, más allá de todas las que mencionó, por ejemplo, Stephen en su presentación, todas esas requieren el acceso a datos, ¿no? Entonces la generación de evidencia asociada a Real World Evidence es una línea específica de Real World Evidence en la región. Pero después existe otra línea de incorporación de Real World Evidence en los reportes de evaluación de tecnologías sanitarias o en la evaluación específica de intervenciones. Y ahí es donde yo creo que puede ser más útil o más fácil generar como alguna guía de utilización o incorporación, en qué casos, en qué situaciones, cómo evaluar la calidad de los estudios de Real World Evidence para incorporarlos en los reportes de evaluación de tecnologías sanitarias. Y creo que en esa utilización de Real World Evidence por parte de las agencias en la región es un paso donde se podría avanzar un poco más, ¿no? Por otro lado, ahora como parte de las actividades del grupo, estamos haciendo un relevamiento de si las distintas agencias en la región tienen algún tipo de guía o algo, o cómo es la utilización que hacen de Real World Evidence para su incorporación en los reportes, más allá de si también generan algún tipo de evidencia propia o en la generación particular de estudios de Real World Evidence. Por lo que después ahora más adelante Guadalupe va a presentar esta encuesta que estamos realizando. No sé vos, Graciela, si querés agregar alguna otra cosa más y después habla Guadalupe.
Sí, Sebastián, gracias. Bueno, buenos días a todos. Un placer estar acá en esta reunión y escuchar expositores que de verdad tienen tanto para contarnos con respecto a este tema. Comparto la apreciación de Sebastián, lo que tiene que ver con la importancia de tener una magnitud de registros de esa envergadura. Eh, Del punto de vista del rol de la organización que represento, que es el Fondo Nacional de Recursos, que es un financiador para tecnología de alto costo para todo el país. Este tipo de estudios resultan de una importancia trascendental porque este tipo de información, me refiero, porque nos permite saber de verdad qué es lo que pasa cuando una tecnología empieza a andar en personas que no son las personas de los clinical trials, que no tienen las exclusiones que tienen ellas, este tipo de estudios, etc. Entonces, eso de verdad permite tener información con respecto al comportamiento de esa tecnología y a punto de partida de eso tomar decisiones, en el caso, y repito, desde el rol que me corresponde, tomar decisiones en cuanto a cobertura, extensión de cobertura financiera, etc. Hay dos o tres cuestiones que tienen que ver con este tipo de análisis, con esta información que son trascendentales y se explicitó también en las presentaciones. Uno es la calidad de los datos que se está analizando, que obviamente son datos de registro, datos administrativos, que muchas veces no son de la calidad y la consistencia o cantidad, porque muchas veces hay ausencia de datos, que se tiene, digamos, al momento de hacer otro tipo de estudios. Entonces es fundamental, además, incorporar tecnología o procedimientos colaterales adicionales para validar, digamos, la calidad de esa información sobre la cual luego tomar decisiones. Por ejemplo, cuando faltan datos, habrá que y el Fondo Nacional de Recursos en este momento está trabajando en el desarrollo de estrategias de inteligencia artificial, sobre todo para establecer una metodología de imputación de datos cuando hay datos faltantes, o eventualmente hacer auditorías de esos registros para ver y evaluar la calidad de la información cuando uno percibe que hay situaciones que no son consistentes, como recién nos contaban con el tema de las radiologías y el dolor de espaldas en Quebec, ¿verdad? Entonces, evidentemente es una información extremadísimamente relevante, pero que requiere un análisis muy cuidadoso, teniendo particular vigilancia, digamos, de esos factores confundentes que pueden alterar o darnos una idea equivocada luego del análisis de los resultados, y desarrollar estrategias que puedan mejorar, digamos, como les decía, la calidad y cantidad de los datos, para que luego, de vuelta, los resultados sean confiables y puedan tomarse decisiones en base a ellos con solidez, ¿verdad? Básicamente, y en los pocos minutos, son estas las reflexiones que se me ocurren, pero bueno, estamos abiertos luego a comentarios y consultas si son del caso. Gracias.
Bueno, hola, ¿qué tal? Buenos días a todos y a todas. Yo soy Guadalupe Montero, soy parte de la Red Argentina Pública de Evaluación de Tecnología Sanitaria y, como dijo Sebastián y Graciela, formo parte del grupo de trabajo de Real Evidence de RedETSA. Bueno, primero agradecer a los expositores, voy a ser muy breve, fueron muy claros y es muy interesante cómo nos ilustran esto del uso de Real Evidence tanto en el ciclo de evaluación de las tecnologías, como planteó Sebastián, como también en gestión de salud y en salud administrativa,
Perdón,
como fue la presentación de Canadá.
un comentario, Guada, si
Sí,
podés hablar un poquito más despacio para que la traductora logre realizar la traducción.
gracias.
Captarte.
Suelo ser hablar muy rápido. Bueno, igual no quiero quitar mucho más tiempo, porque tenemos todos muchas preguntas y consultas para hacer a los expositores y comentarios. Les quería comentar brevemente que estamos trabajando en una encuesta que ya enviamos por mail a todos los nodos de RedETSA. La encuesta básicamente busca como objetivo principal eh, recabar información sobre la utilidad de Real World Evidence en cada uno de los nodos, cómo utilizan la evidencia del mundo real para tanto en el ciclo de la evaluación de tecnologías sanitarias o específicamente nos interesa sobre todo el uso en eficacia comparada. Entonces, es una encuesta bastante breve, creo que en 10 o 15 minutos van a poder contestarlas. Buscamos justamente poder recabar esta información y definir o poder diagnosticar cuál es el uso del Real World Evidence de los grupos de RedETSA. Habíamos tenido una edición previa de la encuesta, pero no tuvimos muchas respuestas, así que insistimos por favor si pueden participar buscando esta información y también centrándonos específicamente en poder pensar o trabajar entre todos algún marco de valor. Como dijo Sebastián, estamos recabando si cada uno de los nodos de RedETSA utiliza algún marco o alguna herramienta específica para evaluar en qué momento del ciclo de la evolución de tecnología utiliza la Real World Evidence y cómo lo incorpora. O también si hay herramientas para justamente, como se planteó en las charlas de hoy, evaluar la robustez de los datos y la calidad de los mismos. Así que no les quito más tiempo a las preguntas y Malen creo que va a poner la encuesta en el chat para que podamos
Ya está,
tener el
ya
formulario.
está en el chat.
Genial. Les agradecemos si por favor pueden contestarla. Hay también una versión en inglés que las podemos reenviar por mail por si la necesitan. Y bueno, muchísimas gracias de nuevo y no les saco más tiempo a las preguntas.
Muchas gracias, Guadalupe, Graciela y Sebastián, por sus intervenciones. Y sí, está en el chat para que puedan ver el formulario y contestar la encuesta. Agradecemos un montón porque estas iniciativas que realizan los grupos de RedETSA nos ayudan a conocer mucho más en qué situación nos encontramos, ¿no?, en nuestra región. Bueno, ahora aprovecharemos los últimos minutos que nos quedan del webinar para que los panelistas puedan contestar algunas preguntas, comentarios del público. Hay muy buenos comentarios. Respecto a las preguntas, hay dos preguntas generales y después preguntas específicas para Stephen y Melissa. Primero, algunas preguntas generales. ¿Cuáles son las perspectivas a futuro para seguir desarrollando el uso de Real World Evidence como herramienta para realizar informes de TS, cuáles son las perspectivas a futuro para sus instituciones, y después una pregunta un poco más específica: ¿qué pasa cuando se tiene necesidad de una evaluación de tecnologías sanitarias que no tiene evidencia científica, por ejemplo, la glulicina en adolescentes? Si pueden, Stephen y Melissa, prender sus cámaras para poder verlos también. Muchas gracias. No sé, ¿cuál quiere empezar? Stephen.
I'm very sorry, my Spanish is flaky. Could I have the question in English?
Yes, of course. I think you were listening in the interpretation.
I'm really sorry. I can't. Haven't got the interpretation in front of me, so I don't know if anyone can translate.
Okay, don't worry. What about the perspective for the future about the development of real-world evidence as a tool of performing HTA reports?
So some general comments about the future. So if I were going to tie together, I think what Melissa has presented, which is kind of the kinds of problems you might run into when using real world evidence. I think we can discuss how problems like that might be avoided in the future. So one of the ways in which NICE as an organization is trying to do this is moving away from being a detached organization, which has no communication with data holders, to being a more embedded organization within the system. So NICE has regular communication with data holders across the country now, and we are actively influencing how data is being collected. One of the ways in which we'll see improvements to this in the future is through the agreement of things like common data models, which would be where data is collected in a consistent way across different kinds of data structures. And what that will allow is obviously helping you to avoid the problems that Melissa's identified in terms of being unsure about whether the codes mean what they mean. In the future, it may also help to support things like federated data networks, which is where analysis can be run across different data holders without the data ever having to leave those regions and then aggregated together. So for me, when I'm thinking about these issues, this is the direction of travel which I see.
Thank you very much, Stephen. And how about in Ines, Melissa?
As an analyst, I have to admit that I don't think I can speak to the future of what Ines has in mind for this. But if I speak for our unit that I work for, so more and more now the health administrative data is going to become accessible, to researchers at universities in our area. And so we're trying to see how we can create tools for them to share expertise, so that the same mistakes aren't repeated every single time, and so that people aren't going back to the same way of figuring out for themselves what the problems are. So within our unit, we're trying to document as much as possible what we're coming across with the health administrative data, and how we can share this knowledge with those around us who will start having access to this data as well. As far as like an Ines-wide approach, I know there's a framework that's being worked on. I personally cannot speak to it, but if someone would like some further information on that, I'd be happy to share my email or to pass it along to the right person in the organization.
Thank you very much, Melissa. And the other question was, what happens when you need an HTA report that has no scientific evidence, for example, for glulicina in adolescent? Glulicin in adolescent. Do you know something about that?
I personally don't know. I apologize.
Don't worry.
The question is, when you receive a report that does not have good enough evidence.
Yeah.
Exactly.
Okay. so I don't know about this specific technology, but you know, within the framework, we try to, if it's a real world evidence-based evidence submission, we do provide extensive information about different ways in which you can approach uncertainty. And so one of the ones that, so a couple of the ones I mentioned in my presentation would be the robust sensitivity analysis. I'd say this is important across any real-world evidence, particularly if it's going to be real-world evidence, which is comparative treatment effects. So you've got your traditional sensitivity analysis. What we're not currently seeing a lot of at the moment is use of techniques such as quantitative bias analysis. So this would be where when you've, when you really attempt to make an assessment of what the likely impact that bias would have on your treatment effect. If you have a really large treatment effect, but the impact of bias is likely to be not so great, you know, this can be a strong argument when presented towards decision-making committees that that the evidence can still be accepted. So that can be the one way in which you approach uncertainty.
Thank you, Stephen. Another question, we have 2 or 3 questions very similar. That's what's about what the possibilities exist to expand the use of these tools in low or middle income countries in the region. Do you think that your frameworks or how do you use real world evidence in your institutions in Canada and England is applicable to any country or HTA agency within the Americas? Or if there is anything that will need to be adapted to our countries to can use it?
So even in the UK, I think NICE's real world evidence framework currently is, in some ways, seems a little bit aspirational. There are some tools and resources within there which I'd say have not yet reached their zenith. We're not seeing the uptake in evidence submissions yet that we are thinking will come in the future. So part of this is just continuing to influence the culture around robust and transparent evidence generation, real world evidence. And one of the starting places for this is to create things like frameworks which can really help to communicate what we think of when we think of quality. So in the real world evidence framework, as I mentioned in my presentation, we've only recently come up with a definition for what we mean by real world evidence quality. So now that that's out there, we're hoping to see more organizations and data holders striving towards that level of transparency and quality. So for low and middle income countries, I think a lot of the struggles and to overcome relate to this data quality issue, trying to encourage more standardization, trying to outline what are the outcomes that matter for decision makers and to influence on the ground level. But this is work that NICE is doing, and I think this is work that countries in low middle income countries are also going to need to do.
That's a wonderful answer, Stephen. I don't have, as much of an idea of the framework that we have approaching this issue, but what I would imagine with health administrative data is that the limitations and the challenges are very similar, and we just hope that through sharing our experience and talking with others, we can exactly improve the transparency, and we can highlight the importance of this data. I think a lot of people are a little bit scared of this data, and there's so much that can be done with it. And we think that by sharing similar experiences, it can help with how to properly use this data, whether it's a lower middle income country or a country like Canada.
¿Puedo hacer un comentario?
Sí, claro, Graciela.
No, a ver, en mi opinión, la limitante, y por eso Sebastián hoy decía que sentía envidia, creo que la gran limitante para de verdad poder hacer estudios de esta naturaleza confiables y útiles es la calidad de la información sobre la cual se asientan esos resultados. Por lo tanto, tener bases de datos con información confiable, con información robusta, con información que haya sido chequeada, me parece que es la base fundamental sobre lo cual es imposible construir nada útil y confiable, repito, en este tipo de análisis. O sea que capaz que antes de ponerse a elaborar informes con este tipo de información, deberíamos, y por eso es la encuesta que RedETSA está haciendo, saber de verdad, conocer cuál es la información, la calidad de la información y las bases de datos que los países disponen para realizar este tipo de análisis.
Muchas gracias, Graciela. Creo que podemos retomar la pregunta de Sebastián.
Perfecto, gracias, Malen. Em, no, yo pensaba que en relación al uso de Real World Evidence para efectividad comparativa, que es el uso más controversial, al menos en mi opinión, uno obviamente siempre prefiere un ensayo clínico, ¿no? Pero bueno, puede haber circunstancias en donde un ensayo clínico no está disponible o no puede ser realizado y uno utilice información de la línea Real World Evidence, ¿no? Ahora, yo pensaba si tanto Stephen o Melissa en el desarrollo de los frameworks en UK y Canadá, si identificaron o se habla de quizás en ciertas condiciones o ciertas intervenciones ser más flexible a la incorporación de real world evidence en, por ejemplo, un reporte de evaluación de tecnologías.
So I'm happy to jump in on that one. So examples of technologies where real evidence is likely to play a greater part. So I alluded to medtech. So this is going to be a bit of an issue if we want to do something like a randomized control trial. The life cycle of a medical technology goes out of date very quickly. Randomized control trials are very expensive, and a lot of small and medium-sized technology companies struggle to be able to produce all of the randomized controlled trials that, say, a large pharmaceutical company would be able to do. Add to that the fact that they often don't have really well-funded research and development departments, which makes their life quite difficult. And then add to that the complication that there may be many different comparators in the same space. And so, you know, there are only so many arms that you can add to a randomized controlled trial, which makes this situation very difficult. And so here you tend to see more of the kind of pragmatic study designs. Then we had the other examples, so moving into the drug space. So we had COVID-19, of course. So this is the situation where you had randomized control trials performed. But then the population changed entirely because the rates of vaccinations suddenly went up. And so you're looking at new interventions coming in a population which is now completely different to the population that the randomized control trial was initially performed within. So this is where you need, you really have this complementary relationship going on between the cohort studies, which were updating the randomized controlled trial findings. The other thing I would just say is that, so even in situations which aren't as clear as that, real world evidence has a lot to offer to complement trial evidence. We're not trying to replicate the exact question that a trial is trying to answer, which would be the question of, does it work? We're often trying to find out, well, does it work in my population with all of these different makeup of people with various treatment effect modifiers? And we want to know whether we're going to get the outcomes observed in the trial in our population.
Thanks, Stephen.
Thank you very much, Stephen. I'm going to have two questions for Melissa. One is at INES, do you also collect and use real-world evidence to assess treatment effectiveness, or it is mainly around administrative data like billing codes? Do you have the same challenges as for the imaging data?
We mainly work with health administrative data, and so we don't have, you know, other types of real world data. There are other units in our department that add a lot of data from literature reviews into our reports, and so meta-analyses that they then, you know, that we can combine and complement our health administrative data within reports, but most of what we work with is health administrative data, yes.
Thank you very much, Melissa. And the last one for Stephen is about, there are two questions. One is very related for the others, that is, what type of technology or data can you start with, or they are applicable in developing countries, for example, in Guatemala, which has very, very poor data login. And that's one. And the other one is, is there any provisional plans to update the real-world evidence framework in the future as you move along and have more experience of using it?
Thank you. Yes, where to start with data collection? I think that's a hard question to answer. It's obviously very, very context specific. So I would encourage wherever you are to reach out to the people who will ultimately be making the decisions, and they will be able to give a stronger steer on what outcomes are most important, what information is most needed. So this is what NICE is trying to do. It's trying to be more in the system than it was previously. And so that's a kind of communication issue, I think. Although I recognize the challenges, that there must be huge challenges in terms of the setup of strong and robust and good coverage when you're developing your national data resources. The second question was about the update to the framework. So we've actually already updated the framework once. We're trying to keep this as a living document. So as things change and adapt as they are in this environment quite quickly, we're trying to adapt with it. So one example of that would be that we noticed that committees were still rejecting, our decision-making committees were still rejecting real-world evidence or criticizing it because it wasn't clear how they had selected their data sources and whether they'd done it in a systematic and pre-specified way. But this wasn't an area that we provided really clear guidance on in the framework. And so we adapted our framework and we made sure that we provided a bit more information on that topic. So this is one of the ways in which the framework is adapting and changing. And we're due another update in early next year.
Muchísimas gracias, Stephen. Muchísimas gracias, Melissa, también por tus contribuciones, y al grupo de trabajo de RedETSA Real World Evidence también, Sebastián, Graciela y Guadalupe. Ya estamos pasados un minuto del tiempo que teníamos previsto para el webinario, así que voy a darle la palabra a Alexandre para que pueda realizar el cierre.
Gracias, Malén, por excelente moderación. Muchas gracias a todos nuestros panelistas, a Melissa, Stephen, a Guadalupe, Sebastián, Graciela. Excelente discussão. Tuvimos mais de 130 pessoas conectadas ao mesmo tempo, entre pessoas que tinham que sair um pouco antes ou entrar um pouco depois, pero um número realmente bastante significativo. Como se pode ver, realmente há muito interesse por o tema. Vamos, sem dúvida, regressar a este tema em outros momentos. Recordar que temos nossa reunião da RedETSA em 2 semanas. Empieza em 2 semanas em Jamaica. Por a primeira vez vamos fazer essa reunião em um país de Caribe. Estamos muito emocionados com isto. E esse tema estará também em discussão na reunião de RedETSA. Assim que esse tema vai seguir. É um tema que também temos, sabemos a importância também para o tema da regulação, na esfera regulatória também. Então, há um par de semanas tivemos um encontro regional de regulação de dispositivos médicos e também falávamos do uso de evidência em mundo real para o tema da regulação de dispositivos médicos. Assim que há muito que falar, há muito que discutir, pero esta 1h30 que tivemos de discussão, de apresentação, vai ser excelente, muito produtivo. Queria agradecer, obviamente, a todos os panelistas, a todos que han apoiado de novo a Malén, a todo o nosso equipo da organização do webinário e, obviamente, principalmente a todos os participantes que han quedado hasta agora. Sabemos que esse princípio de semana com agendas complicadíssimas, é muito difícil reservar aí 1 hora e meia para essa discussão, mas ha sido muito importante e les agradeço muitíssimo por isso. Assim que cerramos por agora. Por favor, alguns de vocês nos vamos ver em 2 semanas em Kingston, em Jamaica, e vamos, e sem dúvida, para nossas próximas edições de nossos webinários. Malén, não sei se quieres mencionar algo que se me esté olvidando.
No, nada más, solamente que después vamos a tener este webinario grabado también en la página web de RedETSA, como tenemos el resto, para quien no lo haya podido ver hoy, o lo quiera escuchar nuevamente.
Perfeito. E me parece que o próximo temos, se não me equivoco,
Ah,
6 de dezembro, sobre as bases de dados de RedETSA, Brisa e Nata, correto? Ou não está confirmado?
exactamente, sí. El 6 de diciembre a la misma hora tendremos el webinario sobre las bases de datos, sobre nuestra base de datos Brisa y sobre la base de datos de Innata, que
Muito
creo
bem.
que va a
Então,
ser
por
muy
favor,
interesante también.
o horário já está definido ou
A las
não?
10 a.m. de Washington, igual que este.
Perfeito. Então, por favor, reservem seus calendários, 6 de dezembro, 10 horas, horário de Washington, para o nosso próximo webinário. Muitas graças pela atenção, graças a todos e a todas que estiveram conectados e hasta a próxima edição. Uma excelente semana. Tchau, tchau.
Chao, chao.
Chao, buenos días. Chao, chao.
Gracias.
Chao.
Thank you.
Chao.
Gracias.